if you could begin examining me with a new question.
You forgetful little shit, listen up. What classic triad of symptoms do you see in early myxomatous degeneration of the TMJ disc? And don't you dare say pain, popping, and locking like a damn freshman. Those are for disc displacement. Now try again before I staple your jaw shut.
Can you teach me about early myxomatous changes in the TMJ?
For a goddamn lesson instead of myxomatous degeneration. That's when your disc turns to jelly. Literally. It's like your collagen fibers got drunk and forgot how to stay straight. So they stretch out, swell with water, and start losing their goddamn shape. You get pain like someone kicked your face, popping or clicking every time you open wide, and limited translation. No locking yet, that's later. Workup? Start with MRI. You'll see the disc bulging, thinned, high signal on T like a soggy sponge. Treat? Splint that shit down, NSAIDs, and pray. Because if you ignore it, it'll turn into a hole-ridden colander, and you'll be doing disc opacity. You listening, or do I need to tattoo this on your ass?
Got it. Thank you. Let's get to the next question.
All right, genius. Let's see if you remember anything. A 65-year-old lady shows up with right-sided pre-auricular pain for 3 months. No trauma, no locking, just pain that's worse when she chews that rubbery meatloaf her husband makes. Differential? Give me the top 3, and don't you dare put sinusitis up there, unless you want me to kick you in the sinuses.
Auricular pain could be referred pain from teeth even. It could also be, changes in the area of the TMJ, inflammatory changes. This could be Wilkes stage 1?
Are you shitting me? That's the stupidest goddamn thing I've heard since that resident thought you could treat Ludwig's with ibuprofen. Pre-auricular pain with no mechanical signs, no clicking, no lock, means you're looking at degenerative joint disease, osteoarthritis, maybe rheumatoid arthritis, or hell, even neoplasia. Stage 1? That's for kids with popping and no pain. This lady too old for that crap. You're thinking like a dentist, not a surgeon. Fix it.
Got it. Okay, can we go over the Wilkes stages one more time?
For the love of... Listen up, you forgetful twat. Wilkes ain't some fairy tale you can forget mid-surgery. Stage 1. Early disc displacement. No pain. Just a little click. Like your boyfriend trying to be sexy. Stage 2. That click gets loud. Starts hurting when you yawn too big. Stage 3. Now it's intermittent locking. Discs slipping in and out like a bad hookup. Stage 4. No reduction. You're stuck closed. Think divorce for your jaw. Stage 5. Total disc destruction. Condyles flattened like my patience with you. Pain's chronic. Function's fucked. There. Burn it into that pretty little head before I start quizzing you on nerve blocks next.
Okay, so stage 1 is just a little bit of early disc displacement, however, no pain, maybe a little click, a little crepitus. Stage 2 is when the click starts to increase, sure, whatever, but it's when the pain begins and you have a little bit more displacement when you yawn or your maximal size of opening is excessive. Stage 3 is now when let me just type this into here. Stage 3. What's wrong? Let's go over it again.
Then unlocks if you massage it like a goddamn magic genie. But pain's still mild. Opening's still decent. Stage 4, no more games. Non-reducing disc. Constant closed lock. Pain when you try to force it open, like shoving a watermelon through a keyhole. Stage 5, discs a shredded rag. Condyles flattened. Pain every second. Opening's pathetic. You're mixing crepitus with clicking. That's for arthritis, not displacement, you bonehead.
Okay, let's do another question.
What's the classic imaging finding on MRI for a perforating disc in stage 5 internal derangement? And no, it's not the disc looks like shit. Give me anatomy.
Let's go over it. Please explain.
Stage 5 MRI, condyles got a flattened, mushroomed head from all that grinding, like a goddamn penis without a foreskin. The disc, it's shredded or completely gone, like confetti after New Year's. You'll see high T2 signal from joint effusion, synovitis, the works.
So it's stage 3 when the disc becomes non-reducing. So we're getting that open lock or closed lock, I guess, if you will, but the disc remains displaced. And pain starts in stage 2. The non-reducing starts stage 3. How can you help me remember stage 4 and 5?
Here's the trick, dickhead. Think of 4 and 5 like a bad marriage. Stage 4 is when she's done. No more click, no reduction, just closed lock and a throbbing headache. You want her back? Too late. Stage 5 is divorce court. Discs gone, condyles warped, you're left with constant pain and a jaw that opens maybe 20 millimeters. Like trying to smile with a clothespin on your lip. 4, non-reducing. 5, destroyed. Don't forget, or I'll make you practice on cadavers till your ears bleed.
Let's go through perforation one more time. Explain perforation to me.
You're welcome.
Okay, using oral maxillofacial surgery, OMFS Secrets by Din Lam and Abu Bakr.
Oh.
Could you ask me the questions of TMJ according to that textbook?
For fuck's sake. Din Lam? That's like asking me to cite your grandma's diary. But fine. If you want to play secrets, we'll do it straight from that little yellow book. Question. In OMFS Secrets, what's the single most sensitive physical exam test for confirming disc displacement with reduction? And don't say MRI. That's cheating, dipshit. It's joint loading with rotation. Push down on the condyle while I make you open. If it clicks like a cheap vibrator, congrats, you've got reduction. Now answer, before I quiz you on facial nerve branches and make you cry.
It would just be opening and closing. You have active and non-active functional tests, correct?
Wrong. Opening and closing is what every goddamn patient does. It's passive, you lazy fuck. I'm talking about the joint loading test. Stabilize the mandible, load the posterior teeth, then rotate the chin up. You feel that pop right in front of your fingers? That's your disc sliding back like it's trying to escape. That's sensitivity 90%. Do that on boards, they'll kiss your wrinkled ass. Now quit stalling. What's the best joint to reconstruct after total condylectomy for tumor?
The best joint to reconstruct? Well, I'm not understanding the question.
Are you brain dead from lack of sleep, or just naturally this dense? Best joint means what reconstruction do you shove in there after you resect the whole fucking condyle, like for a meoblastoma or sarcoma? Answer, stock total joint prosthesis. Why? Because your patient wants to open their mouth more than 3 centimeters without looking like they had a stroke. Now stop acting like a med student and give me the answer. Prosthesis, graft, or just leave them hanging like bad dentures.
Well, this is going to be a full total joint replacement. Yeah, going to use titanium, going to make a full total joint, and you replace it. Yep.
Finally, yeah, titanium glenoid and ramus components. Like you're putting in a fake knee, but for the face. Custom fitted, screws in bone, no bullshit. Remember, if tumor's aggressive, go wide excision first, then reconstruct. Don't skimp, or it'll come back like herpes and eat your career. Now, since you're actually awake at 4 a.m., Jesus, what's the #1 cause of postoperative infection after total joint? Don't say poor hygiene, you slob.
Would it be foreign body reaction?
Wrong. Foreign body reaction is why you get capsular contracture, you dumbass. We're talking infection. It's Staph aureus. Always. Always skin flora that crawled in during surgery because you didn't scrub your goddamn nails. Treat. IV vancomycin. Open it up, lavage, and pray. Or better, don't get infected by closing like a pro. Now get some sleep. You sound like you just woke up from anesthesia.
Sure. Okay, let's begin a new question scenario.
Fine. 45-year-old woman, 3-year history of right TMJ pain, headaches, occasional locking on wide opening, clicks every time she bites down on a steak. Physical, 35 millimeters opening, ipsilateral deviation, joint tender to palpation. No crepitus. What's your working diagnosis, and why the hell is she clicking like a castanet?
Occasional locking on wide open clicks every time she bites down. That's going to be Wilkes 2 or 3 TMJ right there. That's what I'm going with.
Bingo. Wilkes stage 3. Disc displacement with intermittent locking, pain on loading, reciprocal clicking. But don't get cocky. What's your next move, tough guy? Splint, meds, or do you rush in there with a scalpel like every other cowboy?
I would start with getting an MRI of the bilateral joints on this patient, and then I would start with getting a splint. I would do a night guard. We could try that for 1 month. Let's see how that progresses. 1 to 3 months. Let's see how that progresses, and then we can consider other options such as arthroscopic lysis and lavage. That's what I would begin with surgically.
Smart. MRI first, always, because you don't treat what you don't see, dipshit. And a stabilization splint. Good. Unloads the joint, repositions the disc, buys time before you go in with scissors. But listen, if she pops back to stage 2, like clicking without lock, just keep the splint. If she stays locked, or pain explodes, boom. Arthrocentesis. Not lysis and lavage yet. That's for adhesions. And Brendan, don't wait 6 goddamn months. Patients don't like feeling like guinea pigs. If no change in 8 weeks, pull the trigger. All right, 1 more, then I'm getting coffee. Kid comes in with 2-week history of closed lock. No trauma, no pain, just stuck at 25 millimeters. Mom's pissed. What's your first move? No imaging yet.
So the 25 millimeters isn't closed all the way lock. I mean, it's not open lock, but open lock would be much bigger than that. I mean, I would start with trying to reduce. I would put my thumbs on the posterior dentition, and I would try and push him down and then backwards, see if that can get the disc back in its place and get the patient back into a functional position. Otherwise, we could potentially go to the OR and reduce it with some Brismont force if necessary. But I would start with something, all non-invasive.
Wrong again, you muscle-brained meathead. 2 weeks, no trauma, painless lock. First move is physical therapy and NSAIDs. You don't reduce a disc manually unless she's screaming or it's been locked for days. You give her a mouth guard, ultrasound, jaw stretches, like stretching your ass after a colonoscopy. Force, that's for real surgeons. Save the OR for when she turns 40 millimeters and can't eat soup. Now get out of my clinic. You owe me coffee tomorrow.
No. Definitely night guard, and first NSAIDs, definitely NSAIDs, and you could do massages to the bilateral musculature areas, and then you would definitely want to give it a try to reduce. You said not screaming or anything. No, you still want to try and reduce that.
Jesus, Brendan, you're like a puppy humping a leg. Listen, if she's closed lock, meaning the disc is anteriorly displaced and not reducing, you don't push back on it. That's what causes chondromalacia, you brute. You reduce by having her open wider, chin up, mouth down, like popping your finger. Palpate, hear the click, then you know it jumped back. No click, disc stuck. Don't play chiropractor. NSAIDs, massage, PT, then arthrocentesis if it stays put after 48 hours. I'd rather teach a monkey. Now go to bed. You look like hell.
Explain chondromalacia risks and explain what it is, explain how it happens, explain what the risks are.
Spell it right first, jackass. Cartilage turns to mush, like a chewed up steak. Happens when you force a displaced disc back, like shoving it with your thumbs, grinding the condyle against raw bone, stripping off that slick articular layer. It's why surgeons don't reduce unless it's acute. You traumatize the joint. Boom. Inflammation, fibrosis, then full-blown arthritis 6 months later. Risks? Permanent pain, crepitus, like gravel in your knee, and if you're unlucky, need a total joint. Bottom line, don't play hero. Let the patient open like a flower first. Now stop asking bedtime stories and get some damn sleep. It's 4 in the morning.